Hello everybody. Thank you for joining me for this Instagram live session. My name is Gabriel Corral. I'm a plastic and reconstructive surgeon who specializes in gender affirmation surgery. I really want to thank all our viewers who really sent several emails to our practice with questions that they want to address during this next hour or so. So please, if you have any questions, just reach out to us. I have my wonderful physician assistant Andrew Hodge is on the other side, really trying to gather all the questions from our followers to make sure that we don't miss anyone. It looks like we have some friends from all over the world. Hi Patti, hi Lauren from Mexico and Panama, and some of our followers here in the US. So many of our followers have asked us about what kind of surgeries we perform here. And the name of our center is the MedStar Center for Gender Affirmation, and we perform all kinds of surgeries, starting from facial feminization to chest feminization, chest masculinization. We perform tracheal shape procedures, and we perform several genital surgeries, including Phalloplasty and Vaginoplasties, as well as Mtodo. So we really offer our patients the entire gamma of gender affirmation procedures. So many of our patients have to undergo this surgery, and it could be a top surgery or a bottom surgery, and they have asked us if we perform revisions. We perform plenty of revisions for several reasons. For top surgery, either patients who are unhappy with their scars or their contour, but more importantly, we perform a number of revisions for patients who had undergo vaginoplasty and have developed complications from vaginoplasty, either aesthetic complications or some issues with vaginal canal stenosis. And we do perform this in several ways, so we'll definitely discuss this a little bit further on our outcome here. So I wanted to review with you some of the questions that we have. Many patients are asking about if we use insurance or do we take, it's a cash business. We really focus on addressing patients to try to do everything through insurance. And if insurance has difficulty with us, we try to work with them to try to get the authorization. We do perform peer-to-peer for certain procedures to try to really argue for our patients to try to obtain authorization for their procedure. Now with the coronavirus, of course, we have implemented a lot of telemedicine, and we are certainly doing a lot of virtual consultations for our patients. We get patients from all over the country and from out of state as well, and this has really facilitated the consultation process. I'm primarily based out of two locations. I'm at MedStar Franklin Square in Baltimore, and I'm also at MedStar Washington Hospital Center in DC, and this is the Mid-Atlantic area, and this is where we perform both of our surgeries. So many of our patients ask us if we work with other specialists. There's questions about who performs the surgery. Is it plastic surgery? Is it urology? And these are, it's very broad, the field of gender surgery. Many of our procedures are performed combined. For example, for our vaginoplasty procedures, I primarily perform those by myself. But if there is a revision procedure and we need to use the help of a robot, then we get involved with our colorectal colleagues who assist us with the robotic approach to the vaginoplasty. For example, many of our patients are requiring peritoneal vaginoplasty, and this is a combined procedure that we do with other specialties. The same thing goes for phalloplasty. We have a combined approach for phalloplasty. We do both type of phalloplasty. We use a radioform phalloplasty or the AOT flap. And depending on how we're going to do it and the stages of the procedure, we try to use your urologist if necessary to perform these procedures. So, many questions surround about vaginoplasty. And is it one step? Is it two steps? What can be accomplished during this procedure? And really, a vaginoplasty is a procedure that is generally performed in one stage. During this one stage, we're able to produce a anatomically pleasing, aesthetically pleasing result with all the components of the clitoris, the labia minora, the majora, and a canal for intercourse if the patient desires to do so. There's also other types of vaginoplasties. there is a colon vaginoplasty or a peritoneal vaginoplasty. And these are procedures that are historically being used for revision cases for patients who have had complications from a regular penile inversion vaginoplasty. And a colon vaginoplasty was really the first procedure that was performed. We performed this generally with the assistance of the robot, in that this allows to minimize the incisions in the abdomen, in which a segment of the colon is used to create the new vagina. And then the colon that was resected, the other two parts get connected to continuity of the canal. And for this procedure, it's a big operation, and the goal is to create a canal that doesn't require dilation. But the disadvantage of the colon vaginoplasty is that you really need to be aware of the amount of mucus that the patient can have long term. So there is some secretion, but sometimes that can be a little bit too much secretion, and that can be a disadvantage for some patients. There's also this procedure. It's a big operation with complications that can be, require other surgeries. So it's not a small surgery. Many questions recently from our followers about peritoneal vaginoplasty and what is it and how to do it. Do you do it? What are the complications? And really, a peritoneal vaginoplasty is really an adaptation of an old surgery in which we use the peritoneum, which is really a shiny lining that we have inside the abdomen, and we're able to use this to create a new vagina with the help of the robot. And it has done very well in my experience. There's no long-term follow-ups of these patients, but in my experience doing this operation for 2 years, patients do well, and the canal does not. It continues to remain open if the patient continues to dilate properly. So that's really, really positive. So, stay tuned, because more and more information will come about this type of procedures with the peritoneal vaginoplasty. We have some questions coming in, so really patients are wanting to find out a little bit more about phalloplasty, and how is that procedure performed, and what is the hospital stay. And really, for a phalloplasty, the hospital stay is generally about 5 to 6 days. And there's different techniques of phalloplasty performed. Is it 1 stage, is it 2 stage, and you really have to make sure that you do the technique that your surgeon feels comfortable with. Every technique of the 1 stage or the 2 stage to create a phalloplasty has its advantages and disadvantages. We certainly advise to do the radioform to make sure that the sensitivity is a little bit better with the radioform, and we advocate to use this in 1 stage. But when we use the thigh, because the blood supply is a little bit more unpredictable, we like to do this in 2 stages and do the urethral connection a little bit later. So, and that's one of the things that we focus on. But the recovery time of a phalloplasty in the hospital, it tends to be about 5 days. So, which is a little bit shorter than a vaginoplasty, which tends to be about 7 days. Some of the common complications that we see with vaginoplasty, like we talked about, I think the most common complication that we see in genital surgery is just problems with healing, things that are just 4 to 5 weeks out. There's an area of a suture line that just tends to have a little opening that requires some wound care. Fortunately, because of the great blood supply of that area, things will heal. So it's important not to panic, just to follow the instructions of your surgeon to allow this area to heal by secondary intention. Just slowly heal from inside out without needing to do much. And the complications for a top surgery are really related to the type of top surgery, mostly related to the contour or the widening of the scars. If the patient needs to have any type of free nipple grafting, then there could be some changes in the nipple graft. The nipple graft can contract, and they can get quite thick sometimes. In patients who are Latinos or African Americans, they can lose the pigmentation of the nipple, and that can take up to 2 years to slowly return. So just hang tight, just wait, and to make sure that you wait before the pigmentation returns. So we have some questions about if we perform AOT phalloplasty. Yes, we do. If we perform a keyhole, and we perform keyhole, yes, but like every patient, there is an indication for the surgery. So we really try to find what surgery is going to be beneficial for that specific patient based on their specific anatomy and their wishes. We follow WPATH criteria, and there's a lot of questions about hormones prior to top surgery. And we really don't require hormone therapy prior to top surgery. The challenge is that we have noticed that certain insurance companies will require a certain amount of time, usually 12 months, and some other insurance company really require no hormone therapy. So it has become really insurance driven, but we haven't found a lot of issues with insurance authorization and hormone therapy. So that's a positive thing. So COVID has really changed the way we practice medicine, and really has put a delay on a lot of our surgeries. I have some patients who are asking questions about when are we going to be able to resume surgeries, and the first step to bring patients safely into the hospital is going to be to perform outpatient surgeries that are much lower risk, that our patients are able to go home during the same same admission into the operating room. So in the patients who require genital surgery, they'll most likely will need to wait probably an additional 2 to 4 weeks before we're able to start that second phase. Now, this is all very variable, as we are waiting to get some more information from the health system to try to determine what's going to be the safest approach to perform longer surgeries. So right now we're focusing on procedures that are outpatient, really, really low risk, to make sure. There's some questions about electrolysis, electrolysis is always recommended after a vaginoplasty. We understand that many of our patients are not able to perform electrolysis or pursue electrolysis for different reasons. Now even more challenging with coronavirus, as patients can't go and obtain the hair removal. There are some home devices that patients can use, and that can be helpful. We also perform the follicular stripping in order to remove all the follicles from the area, and this can minimize the amount of hair growth. There's also a cauterization or burning of the follicles that occurs to prepare the graft to avoid any type of hair to regrow in the canal. But if you can do it, and it's always helpful, electrolysis prior to a vaginoplasty. There's some questions about Mtodo and if we perform this with urologist. Yes, actually all my Mtodoplasties, I actually refer them to my urologist, and he primarily does the Mtodoplasties and I do the Vaginoplasties. And I think it's just better fitted for each specialty, and that's the way we have really come together to work out that situation. There's some questions about Spanish, and if can we perform consultations in Spanish, and of course we can certainly go through the procedures without the need of an interpreter, which I think for this type of complex procedures makes it a lot easier for the patient to feel comfortable and understand the actual details of the surgery. We perform, prior to undergoing any type of surgery, you got to make sure that you understand the volume of the surgeon, the qualifications, and also it is important, there's a lot of detail that the patients need to review prior to their surgery. So it's important to have a good documentation, and the surgeon should give you some information prior to read, to understand the actual procedure and to understand the complications and the actual wound care involved, because the surgery itself is just really a very small part of the actual process of surgery. So it's important to really be aware of, once you leave the hospital, there's still a long journey to healing, and that journey involves supplies, involves appointments to the physician. So you really got to make sure that you have the support and get ready for such a big procedure. It doesn't matter if it's top or bottom surgery, it's important to. There's some questions from Pennsylvania about the length of stay after a vaginoplasty. And we have several patients that come from out of state and from other countries, and we recommend patients to really stay in the hospital with me for 7 days in the hospital. And then if they're out of state and they live greater than 4 hours, we really recommend the patient to stay a week around the area to make sure they're doing well. Physiologically, a vaginoplasty works by either placing of a graft inside the canal or using some sort of flap inside. So, the hospital stay is really not so important, but the amount of time that the vaginal stent should remain in place is important. Because if the vaginal stent is removed too early, then you can really have a prolapse of that area. So There are some surgeons, that many people are talking about, just a 3-day hospital stay post vaginoplasty. In my practice, I'm a little bit more concerned about. I want to make sure that we actually evaluate the area 5 to 7 days in. I want to make sure that I'm present when I'm removing the vaginal stent, and we use a special vacuum-assisted dressing that the patient will need to stay in the hospital, and it will be hard for me to discharge the patient on day 3. I think, in my experience, I really like to see how that patient does for a little longer than 3 days. There's some questions about recovery after vaginoplasty, and I think that in terms of the general recovery and ability to go back to the gym, for example, and the most important question is when can I start having intercourse? And that really takes about 12 weeks for everything to heal. So we generally give 12 weeks of recovery for our patients post-vaginoplasty. Now, this is very variable. Some patients are well healed by week 8, and then some patients really need the extra 4 weeks to fully heal. So those patients who are at a higher risk, for example, maybe patients who are diabetics, who have other problems or comorbidities, may require that longer hospital or that longer recovery stay. So we really want to make sure that you take the necessary time to go back to work. And it's a big surgery. So for a vaginoplasty, you got to make sure that we stay away from that pressure area. You're going to have to be sitting on your side. We recommend the using of a donut in order to avoid pressure in the perineal area. And that can help minimize the pressure and the swelling post. So if you live in a building and you have a tremendous amount of steps to go up, well, that's really not going to be ideal post-vaginoplasty, because there's an incision in that area, and the incision is going to the sides of the groin. So the more movement that you do, the more problems you can have with wound healing. So that's going to be important. There's some questions coming in about the ability to swim and to be able to go to the beach now that the weather is turning beautiful here in the Mid-Atlantic area. And I think that primarily if the incisions are healed, usually about week 4 to 8, we'll let you go back to something like be able to shower and get in the tub. The beach may be okay around week 8 to 12, and I would strongly wait to do any pools for greater than 12 weeks until everything is completely healed, because pools tend to have a high chlorine content, there's a high bacteria content, so I will probably just hold on that before pool activity, for example. There is some questions about insurance, and if we need insurance for vaginoplasty, and we take insurance for vaginoplasty, and we take out-of-state insurance, and we do the same thing for other procedures. So we take not only Maryland insurance, but also out-of-state insurance. There's some questions about insurances that are based on different states that are medical assistance. Well, sometimes we're able to obtain authorizations for those insurances, but that sometimes can be a little bit challenging. Medicare is also an ongoing battle with the government entities to be able to get this approved, but the battle is not over. We'll continue to make some way with those institutions to try to get this procedure approved. There's some questions about meta, and does the urologist also scrotoplasty, or it's a separate stage? And this is from, yes. Actually, the scrotoplasty we perform at the same time in the meta, because the scrotoplasty is really the way we actually close the meta. So many viewers are looking at Mtodoplasty, and really just to explain what it is, the Mtodoplasty is for those patients who are trying to perform the masculinization of the genital area and trying to be able to pee while standing. And what patients do are able to take and use medication over the clitoris to enlarge the clitoris, and using some local tissue, we can actually elongate the clitoris. And the scrotoplasty we perform at the same time in order to close that area. So that we perform initially, and we will put a catheter that will stay for a few weeks until everything has been properly covered. A lot of questions about surgeries in patients who are under 18 years old. So just to make things very clear, in our institution, and this is really dependent on each health system, we do perform top surgery in patients who are younger than 18 years old. Usually I get many patients who are 15, 16, 17 years old, and as long as they have the good support, they come sometimes with their parents, we're able to make an informed decision. A lot of the patients have been followed by endocrinology for a long period of time, so I get on a phone call with the endocrinology and evaluate that patient-specific situation. So For our hospital, we do not perform any general surgery in patients who are younger than 18 years old, and that's following WPATH guidelines, and this may change in the future. We are currently evaluating a patient who is younger than 18 years old for vaginoplasty, so as long as the patient has been followed up by the right clinicians and has been able to undergo the treatment, we can consider that as a possibility, but it's not really our standard of care. Lots of questions coming in about waiting lists. So coronavirus really put really a shift in on our waiting list, and we are currently waiting for about anywhere between 4 and 6 months for a vaginoplasty and the same amount of time for a phalloplasty. So right now we're in the process of scheduling patients for outpatient procedures only. So we're slowly trying to change from phase 1, as I mentioned before, to phase 2 to be able to offer those procedures. There's some questions about dilators and where to purchase the dilators. We're going to give you all the information. You don't have to worry about when you come in for a consultation for a vaginoplasty. There's a very detailed information about what you need to do, what supplies to obtain prior to your surgery. And in that package, there is information about the dilators. And we use gender affirmation dilators. I'm not going to name any company. I don't have any relation to any companies. But those gender affirmation dilators have a specific curve. It's not some patients say, can I use a dildo, for example, or a vibrator of any kind? And no, really you need that specific gender affirmation dilator that has specific bend to go around the prostate as the patient is doing the dilation. So that's really important. And we have found that some insurance can cover the dilators, some insurance do not cover the dilators, but we'll work with you throughout that process. So just hang in there until we get that information. Some of the other questions that are coming in is about the possibility of coronavirus when you're coming into the hospital. So that's a very, very, very important topic, and I think that especially for people who are taking care of other patients who are currently undergoing gender affirmation surgery. And first of all, we are certainly we are making sure that everyone is COVID tested prior to coming to the hospital. So that's the first step. The second step is if you're having any type of genital surgery, you'll be in the hospital for quite some time in isolation, of course, while the patient is when you're receiving your care. It is important to follow the same recommendations as the CDC when the patient go home. Wash your hands, making sure that you wear a mask if you haven't been with this person in contact recently, and making sure that you monitor your symptoms. So it is important to make sure that you follow the same CDC guidelines. There's some questions about vaginoplasty. We currently perform about anywhere between 40 and 60 vaginoplasties a year, and that obviously varies. Some of them are revisions, some of them are primary vaginoplasties. There's some questions about the need for what is the actual psychiatric evaluation pre and post surgery, and we follow WPATH criteria. This is some friends from Panama. Hello, Doris. We really want to make sure that patients are evaluated by 2 mental health providers based on WPATH criteria. And the most important aspect I have to say is that once they have the surgery, many patients don't go back to their providers, and it's really important to go back and talk to your mental health provider, talk to your primary care to make sure it's really a team approach, and it's really important for you to follow up with them, because sometimes patients will have some needs and will need to talk to providers about their changes and their feelings, and that is really important to go back and talk to them. And that's really important. So there's some questions about phalloplasty right now. We're ramping up our program right now, and the goal for phalloplasty this year is about 10 to 15, and that's a combination between radioform and AOT flap in different techniques, which is really our starting volume at the moment. So there's some other questions coming in about the types of top surgery that we perform. So there is, a lot of patients ask me and they send me pictures about, can I have a keyhole? Can I have a perioral only? Can I have a double incision? And really it's really depending on their breast shape and size and their goals. Many patients want to have a more tighter chest. Some patients will have, depending on maybe their height and their weight, maybe they want to have a little bit more of a volume in that area, and it really depends. But we also do a technique in which we can preserve the nipple actual sensation. It's a technique that was originally described for gynecomastia, and it looks exactly the same as a double incision, where you have an incision along the IMF, or the inframammary fold, and then you have an incision around the nipple, but there's no free nipple graft. It's actually the patient's own nipple. But to be able to give that to the patient, it has to be the right patient. It cannot be too big, and you also have to be okay with the fact of having some degree of tissue left behind. So again, really customizing each surgery to that patient and the specific patient's goals. So it's really not just a cookie cutter operations or a menu of operations. We really gotta find out the best surgery for that patient, and that's our job as surgeons and physicians, to try to find what surgery is going to be the best for those patients. One of the other questions that came in is about revisional procedures post vaginoplasty. And really, revisional procedures after vaginoplasty usually are not performed anywhere between 6 months to a year. And most of the procedures are related to either a scar revision, depending on the scars. Some patients want to remove any kind of or contour the labia, and maybe they want to have labia that's a little bit more protruding or less protruding. Sometimes if there is any need for widening the canal, that can be done. One of the challenges in vaginoplasty surgery is that if the patient desires to gain more length, that can be very difficult to obtain once things have healed. So it is very important to really don't miss the dilation. Continue with the discipline of dilating, because once you have lost length, sometimes you get lucky and you can go through the bottom and try to get a little bit of extra length in the OR. But a lot of the times the patient will require a robotic revision or a colon vaginoplasty revision. So it's really a more involved procedure. So really, really important to continue doing the dilation. Really, really important. Now, I want to just go back to some of the questions that we're getting through the Insta. So do we require 2 letters for consultation? Great question. Thank you, Sarah. It really depends on, we really, if you have 1 letter and you would like to come in for a consultation, we certainly allow that. And we're not gatekeepers of any kind. I mean, some insurance company only wants 1 letter for top surgery, and some insurances want 2 letters. So, by now we already know what insurance company or which insurance company requires 1 versus 2. So we can guide you through the process to do that. A lot of times patients require another letter from their primary care physician, which is really a primary care evaluation or a HMP to make sure the patient is in good health for sure. Some of the other questions that we've been getting is about just healing challenges. And there are many healing challenges as you go through this process, especially for patients who are having, let's say, start with top surgery. Top surgery is a procedure that is relatively short and outpatient. Patients do well in terms of pain control, but the healing process can take several weeks, especially if the patient had free nipple graft. So if you have free nipple graft, the graft are going to go through some, I call them moody changes. They really go through some changes. Their blood supply starts picking up after 12 to 14 days, and the coloration changes. Sometimes they have a little scabbing. The actual change of the actual shape of the skin graft will change, and it's important for you to just follow your gender surgeon recommendations, treat your scars, and give it some time. We see a very similar trend with facial feminization. Depending if you do a bossing or forehead contouring or a mandible, patients can have a incredible amount of swelling after surgery, and that process will take several weeks to go back to normal. So it's important to really be patient and follow the recommendations to make sure that you're not pushing the limit, and take the necessary recovery time from this. There's some questions about cosmetic payments, and we really, for the only procedure that we really accept any type of cosmetic or cash payment is for procedures that are related to the chest, like a breast augmentation or a top surgery. Any of the other procedures in the United States, tend to be quite expensive, and we try to go through your insurance company. especially when we're talking about procedures, for example, like, facial feminization, where you have now moved away from, shaping someone's skull using, in the past, we used to really do this in the operating room table and make the decision in the OR. But now, with CAT scans and virtual planning, we can plan the surgery way before the actual surgery date. So we actually will have the patient get a CAT scan, and we will actually talk to the company and be able to do a three-dimensional CAT scan to be able to see exactly where are we going to make the cuts in the skull, how much bone are we going to trim. Same thing with the mandible. And the beauty of it is that we can now share this with our patients prior to surgery. So we can show the patient the surgical plan prior to surgery, so that way they're aware of the intervention and they're more educated about what's actually going to happen to their face and how we're going to accomplish making those changes that they want. Very, very important. Some other questions coming in. Does the penile length affect the ability to have a vaginoplasty? It's a great question. I think penile length is important. In the past, the entire penile length used to be inverted. That's why it's called a penile inversion vaginoplasty. And the goal of that inverted skin was to create and lay the vaginal canal. But things have changed, and like everything in medicine, there's more technology, there's more innovation. And for patients who the penile length may be shorter, we actually use less of a penile length and try to use that skin to actually create the labia minora, and use the use of skin grafts to actually create the new vaginal canal. And the skin graft can come from different areas. It can either come from the scrotum, but patients who have been on hormonal blockers or prepubertal blockers may not have a lot of scrotal skin. So some groups like to use the skin graft from the thigh or from the groin area with an incision on the groin, like a V shape. I really prefer to use an incision that looks like a small tummy tuck scar right at the bottom, and I think that can be hidden in a bikini very nicely, and that's where we take our skin graft if we need it to. So, to answer your question, really, it does not affect your ability to have a vaginoplasty. It just has to be, again, modified to be able to do it in that specific patient who has been on hormones and has had some atrophy of the penile skin. So that's going to be important as well. So we have some questions about the dilators and how often. Well, that's a very common question about, how often do we do the dilators and what sizes and where do I start? The first and most important, after a vaginoplasty, there is a determined amount of width that we can obtain, because the limitation in boys versus girls is the actual bone, and we can only go the width of the actual bone allows it. The depth is variable, and the width is the actual limiting factor. So your surgeon will tell you specifically what size of dilator or what color to use, and you're going to start exactly with that color, and then you're going to start dilating usually 2 or 3 times a day, depending on each patient protocol. Each surgeon has different protocols. Our protocol is really to use a dilation 15 minutes at a time, and we use that 3 times a day. We recommend patients to really be prepared for a vaginal dilation. You really gotta lay on your back, relax, put pillows between your legs, and really put some music. Just really get prepared for that dilation, because it's really important to be mentally ready for that. The dilation will get easier as you go through several weeks post-surgery, and by the week 8 or week 12, the dilation becomes much more easier. Vaginal swelling, a lot of questions about vaginal swelling post-vaginoplasty. And very, very common. Patients come 4 weeks after the surgery, and the vaginal swelling is really impressive. And it just really takes some time. When you sleep, put a pillow or 2 behind your pelvis and elevate your pelvis, and that can really help the amount of swelling. Ice is your friend for all these types of surgeries. That can help minimize the actual swelling. But going back to some of the dilation question, it's really important to increase your size as you're going through the process. And also remember to go one size down on your dilator to make sure that you can reach the end of the vaginal canal, because a lot of the patients start with one dilator and they may not go all the way through because the canal starts to narrow, and we can use a smaller dilator will allow that canal to stay open at the end. So that's really, really important. what kind of treatment do we use for scars? So scars, a lot of questions about how do you do your scars and how are going to be my scars post-surgery, and nobody wants ugly scars. We use, I think most plastic surgeons will use a multiple layer closure to minimize the scarring, but we use a scar treatment protocol after your surgery, especially for top surgery, in which a lot of our patients have scars in the inframammary fold area. And the scar, as you travel from the middle to the sides, it gets thinner and nicer, but the scars in the middle of the chest get a little bit wider in some patients, and the reason that happens is because motion and mobility tends to widen those scars. So we recommend using a scar cream, but in addition to that, silicone sheets have become quite useful. So you can buy the silicone sheet anywhere, and they come in different lengths and shapes. I'm not going to mention any brands, but they're really important to use, and just really important to understand that scar healing takes several months. So the scars can get bumpy and red for about 6 to 9 months. And it's not until month 9 and 12 that the scars will start fading and becoming really more supple and softer and start getting disappearing. But it requires some work. It's not going to happen by itself. And a lot of patients, you're usually about 3 months out, it's hard for anyone to continue, but if you're disciplined and you continue putting the medication, it will continue to improve. So really treat your scars. And the same thing happens with breast augmentation. Fortunately, the breast augmentation scars are much smaller, and we use something called a funnel, which is almost it's actually a plastic funnel that allows to put large implants through very small incisions. And so this have really helped us minimizing the scar after breast augmentation. Lots of questions about where to put the scars, and patients who are having breast augmentation, we really prefer to use the scars that are located in the bottom of the fold and not going to the areola, because going through the areola has been associated with increased capsular contracture, and capsular contracture is really that scar formation that happens after an implant. So that would be important to try to avoid, because you may not see that capsular contracture for several weeks, and then things can start getting encapsulated. Many questions about bottom of top of the implant, top of the muscle or below the muscle, which one is better? And it really depends. Patients who are really thin, who don't have a lot of coverage, well, if you put an implant behind the skin only, you can sometimes see the ripples of the implant, or you can even palpate the implant. That is called rippling. So we want to try to avoid that. In those patients, we really advocate to put the implant below the muscle to really camouflage that potential for rippling. Some patients who want to undergo larger implants, who sometimes have a very strong pectoralis muscle, well, those patients may benefit from more of an implant above the muscle in order to minimize the amount of animation deformity. And animation deformity is when patients have implants below the muscle, and they go and try to reach, or they go vacuum, and that implant moves based on the muscle contracture, and that can be really annoying for patients. So in order to avoid that, we try to put those implants really above the muscle. But again, every surgeon will give you a different explanation on how they do it and why they do it. But right now we're using mostly highly cohesive gummy bear implants for augmentations. They tend to have a very natural feel. They last for longer than saline implants, because saline implants can actually leak from the valve they have in the back. So we prefer to use silicone implants. There's some questions coming over about the time for a phalloplasty and the function and how long does it really take the finished product. And phalloplasty is a procedure that takes 2 years to complete. And patients and providers get really confused. Is it 1 stage? Is it 2 stage? How many stages do you do a phalloplasty? And really, to make it really simple, I just want to point out that the timeline will be 2 years. The 2 last procedures that we do in a phalloplasty are going to be the placement of a penile prosthesis or placement of a testicular implant. And to be able to do that, all the actual phallos and the plumbing has to be working well. But more importantly, sensation has to be completely restored before putting a penile prosthesis, because the complications from a penile prosthesis are quite high. The penile prosthesis can actually erode through the skin. If the patient is not able to feel that, they can develop some infection. So the first stage will be the creation of the phallus. And some centers, like we do in the radial form, we connect the urethra at the same stage. And then you heal from that, and then you wait a year, and then you consider having, any kind of implants. Some centers do a fallow first, either an AOT or a radial form. Make sure that the actual tissue that was transplanted has good blood supply, there's no healing issues, and then connect the urethra. And that has a lot of advantages because you can make sure that the actual wound has healed, and then the actual connection to the urethra will be the second stage once the fallow has been created. So that's a 2-stage phalloplasty. And then later on, you go to proceed to make sure that you have the scrotal or the testicular implant. So the whole process would take about 2 years. And it's very, very variable between one patient or another. And not every patient wants to have an option or, of having an implant or a penile prosthesis or a testicular implant. So again, really, really variable. There's some questions about BMI and body mass index in vaginoplasty or phalloplasty and top surgery. And, we'll start with top surgery. We recently published a study about high BMI patients on the Plastic and Reconstructive Surgery Journal for top surgery, and we found no increase in complications in our patients. But patients who have a little bit of a higher BMI can have a higher revision rate. What does that mean? Well, the patient can have a little bit more excess tissue on the sides. They call it dog ears, and those can be removed either in the office or in the hospital. And patients can have a little bit more of a wide scar based on the fact of their arm movement and the tension in the scars. So top surgery is very different than general surgery. For vaginoplasty and for phalloplasty, we really want that BMI to be under control, less than 35, for several reasons. We know that high BMI patients have poor complications have a higher complication in terms of wound healing. But also for a vaginoplasty, if the patient has increased BMI and they have a little bit more of a obese abdomen, some patients have a very difficult time trying to look down and be able to dilate. And if you're not able to look with a mirror, even if you're using a mirror, you can actually injure yourself and create trauma to that area. So it's important for everyone to be fitted and to make sure that you're going to have a smooth postoperative recovery. And I think it's more important of that for a vaginoplasty than a phalloplasty. I think the BMI comes to an issue in a phalloplasty because of the thickness of the flap. And where does the flap comes from? High BMI patients will, if the tissue in the thighs is too thick, then the radial form, it will be an option in using the radial form will give you that double tube technique. We're able to roll the skin, but again, we got to make sure that the fat is distributed in a certain way to make sure that the patient minimizes complications. We do a lot of combined procedures, and what is safe? Well, many of our patients want to have a vaginoplasty, and we combine often with a breast augmentation, and we really combine also for example, a tracheal shave. And we would do these 3 procedures in one stage. That can take us about anywhere between 5 and 6 hours. And the amount of blood loss during this operation is really minimal. So I consider that a safe practice to be able to combine these two. If the patient wants to have a vaginoplasty, for example, and maybe a small facial surgery like a rhinoplasty, that would be okay. But when you start doing facial feminization, forehead contouring, mandible surgery, I like to leave those interventions by itself because the patient is recovering from a facial area. Their vision may be a little bit impaired because of the swelling around the eyes. I really don't want to put that patient to any problems with dilation, for example. So facial feminization cases, I combine procedures with vaginoplasty and breast augmentation and tracheal shave. Phalloplasty procedures tend to be by itself. We don't perform chest masculinization on phalloplasty just because the phalloplasty in itself, it's a long procedure depending on how they want to do it. So we try to do this procedure separately for our patients. So many patients have inquired about the use of a dihydrotestosterone gel. to try to apply in the clitoris prior to a Mtodo. And in a specialty pharmacy, we can give that information. You can obtain that gel. There's other gels with different names that have this, that can accomplish the same. There are some websites where you can actually purchase a little vacuum that you can use for the clitoris. If not, you can fabricate one. It's very easy, and we can take you through that process on how you can fabricate if you're thinking about a Metodo. But that was something that we need to do. And sometimes, even if you don't use the gel or the vacuum, even with just the proper hormone therapy, there will be changes in the clitoris, and the surgery can still be performed. So I don't want you to be super concerned if you can't find that medication, for example. We can definitely work around it. Some other questions about intercourse or having sex after phalloplasty. And some patients who have completed the treatment, they are done with the first stage and the second stage, meaning they have a phallus and the urethra has been connected, and they're urinating through the phallus and they're doing well, but they still haven't recovered the sensation. Many patients inquire, well, I have the phallus, I'm excited, I really want to try to start using it. And there are some techniques, using a condom and using a coband can be used to really put around the phallus to be able to create some stiffness for intercourse. And once the patient has gained sensation, then we can actually talk about the possibility of placing a penile prosthesis in it. So there's definitely ways around that. There are some questions about the post-op environment in the hospital after vaginoplasty. And that's a very good question. I think that there are many surgeons performing these surgeries in outpatient centers, and like many of our followers mentioned about 3-day vaginoplasty, and maybe for some centers and some areas that would work. We have a gender affirmation unit in our hospital here in Baltimore where all our patients come in after their surgery. It's a little bit of a larger suite. There's a nice sofa for family members to stay. Now, this is obviously something that may be variable right now with the coronavirus, but historically, it has a full bathroom, so we can actually show you how to do the dilation and how to do the vaginal douching after your vaginoplasty. So it's really a nice center, and the nurses are used to. They have treated many patients who have undergo vaginoplasty and different gender affirmation procedures. So it's really a place that I feel comfortable my patients are going to after the surgery, and that's really important. Just to wrapping up, there's some questions about the differences between a penile inversion vaginoplasty. There's some questions about a peritoneal vaginoplasty, and patients are inquiring about one versus the other. Which one would I do, and what are the plus and minuses of other? Well, the penile inversion vaginoplasty is a procedure that has been around for many years. It was originally described in the 1960s, and while we're creating that area, that space of the vaginal canal, we can obtain a good amount of canal depth. And the vaginal canal depth is really depending on the anatomy of the patient, because the pelvis is separated by the abdomen, and we can only create a canal within that pelvic space. There's a little layer that covers the abdomen from the pelvis, and that's really the end point of the dissection. So a penile inversion, we can easily obtain anywhere between 5.5 to 6.5 inches in a penile inversion vaginoplasty, and it's an operation that works very well. The patient, as long as the patient dilates post-surgery. We really only advocate a peritoneal approach for some cases who want a revision, because it does require someone, and this is a robotic surgeon, to go in the abdomen. So you're really creating some scar tissue in the abdomen, and then you're mobilizing the tissue inside. So we really reserve this for revisional cases, primarily because also nobody has done thousands of peritoneal vaginoplasties yet. So we don't have long-term outcome on this procedure. It's a very useful procedure. I would tell you that 100% of my patients have been pleased with this procedure, but we don't have long-term data. I can tell you that inside the canal post-peritoneal vaginoplasty, it looks very, very good. It looks like it has a good blood supply, almost like vaginal mucosa in a cis female. So I think the jury's still out. There's still more research that we need to do. And I invite to make sure that we as surgeons really trying to continue to innovate and find ways to help our patients and minimize any other complications. We are about to hit the 1 hour mark. I really want to thank everybody for watching. You can visit my website at www.drdelcorral.com or this Instagram page. Please email me your questions, any comments, and I will see you back next week. We're going to do an Instagram live about top surgery and the 5 most common questions about top surgery. Thank you for watching.